I'm Myron Posniak from the University of Wisconsin in Madison. Today we're going to talk about portal hypertension. We'll review the basics of liver disease, how cirrhosis affects blood flow into the liver, and then we'll go through abdominal varices and how where they are and how they can complicate life for a surgeon. We're going to review the normal Doppler flow profiles. We'll talk about hemodynamic changes of portal hypertension, and then we'll go through varices. So just a brief review. Hepatic artery, portal vein next to each other in the porta hepatis. That's the flow coming into the liver. And then the outflow is at the opposite end of the liver via the hepatic veins. Hepatic artery should have a nice brisk upstroke in systole, a diastolic velocity of about 0.2 meters per second, and a normal, relatively low resistive index of about 60 to 70%. The portal vein, relatively uniform velocity, not too much periodicity, and a velocity of about 0.2 meters per second. The portal flow really doesn't go very quickly through the liver. It just percolates through. The pressure gradient between the portal venous system and the right atrium is relatively small, so the velocities are not all that great. The liver vascular index is a comparison of portal vein velocity and end diastolic velocity. These two velocities should be relatively similar. That's normal. And you can do it as a side-by-side tracing like this, or the big gulp, as I call it, where you open wide and capture both tracings in the same image. So the hepatic veins, typically there are 3, 4 within a centimeter of the right atrium. There are a few accessories like the accessory right hepatic or the caudate veins, these little guys that punch directly into the inferior vena cava in the central part of the liver and drain the caudate lobe. That's why it behaves differently in cirrhosis. That's why you get caudate hypertrophy. But the periodicity, the hepatic vein waveform, should have two steps forward, one step back. This is the normal triphasic waveform, and it is due to the atrial contraction causing a brief reversal of flow, known as the A wave, and then flow surging forward into the empty right atrium during the S component of the flow. It's slowing, and then the tricuspid valve opening, and then flow surging forward again into the ventricle. That's the D wave. Basically, 2 steps forward, 1 step back. Again, I like to use the term periodicity for velocity variations on the hepatic venous side. When you take somebody's pulse, you put your finger on their artery. So I reserve pulsatility for arterial velocity variations, periodicity for venous velocity variations, and then phasicity for changes in velocity that are due to inspiration, expiration for expiratory variations. All right, the normal liver gets about 25% of cardiac output, 1.5 liters of flow per minute. Portal vein 2/3 by volume, artery only 1/3, but artery provides 90% of oxygen to the liver. When you have liver disease, the artery supplies the disease process. The disease process doesn't want portal venous blood. It's got no oxygen. The nutrients are in the artery. The portal venous blood is basically, it's coming to the liver to be processed by the hepatocytes. So when you get liver disease, velocities start to change. Hepatic arteries go up to supply the disease process. Portal venous velocities go down because that blood has a harder time getting into the liver. And then you have this disparity in the liver vascular index. Typically, the end diastolic arterial flow is greater than portal flow. Now, this is unfortunately nonspecific. There's a lot written about this in the Japanese literature, and very early on they were eager to see that it was sensitive for the diagnosis of hepatocellular carcinoma. Well, unfortunately, it turns out it's not very specific. Anything can cause this, including hepatitis from any of these insults. Tumors like lymphoma or metastatic disease can do it. It's really nonspecific. Now, I got one quick comment about compensatory flow. I've seen authors discuss this increase in arterial flow as compensatory relative to portal venous velocity decrease. And that's really not an accurate concept. The hepatic artery, it's supplying the disease process. If there's tumor, there's neovascularity with arteriovenous shunting. If there's inflammatory disease, there's hyperemia. And so the artery, which supplies the disease process, the flow surges forward in that artery. The portal vein, on the other hand, it's simply bringing blood to the liver to be processed. If the liver becomes diseased, it's not going to be as acceptant of the flow coming into the liver via the portal vein. If there's tumor there, it's simply replacing that liver. And the sinusoids don't even exist for this portal flow to come in. And so those velocities go down. Okay? So is this index useful? Well, how often have you imaged a liver and you've seen this? You see this starry sky liver where the porta hepatis fat, the little portal triads, stand out brightly against the background of a liver. And you'd think this is so because it's an edematous liver. Therefore, it's disease, but you're not certain. You don't know. Maybe the liver enzymes, you don't have those available to you. So do you make the call or not? Well, I would encourage you to get a Doppler tracing and then see what that liver vascular index is. If it is altered, then make the call. Say this looks like an edematous liver, and then maybe the clinician will draw liver enzymes. Maybe they'll consider some other studies to find out why that liver looks the way it does. Now, I have one bone to pick, and that is on nomenclature. The flow that is going into the liver is normally hepatopetal with a T. It is not hepatopedal. It has nothing to do with your feet. All right, this is people make this mistake all the time. The reverse flow is hepatofugal, and the analogy is centrifugal force versus centripetal force. All right, that's spelled with a T. So if you forget, maybe that's a good way to remind yourself. Do not call it hepatopedal. All right, the degree of main portal vein flow reversal correlates with the severity of the liver disease. As the liver disease gets worse and worse, it shuts down and portal velocities will decrease to zero and then start to increasingly reverse as the disease process gets worse. That patient who has that perfect degree of liver disease so that their portal flow is relatively stagnant is easy to make a mistake and call it thrombosed. Now, I've got a little trick for you to avoid that, and that is to have the patient do a Valsalva maneuver. Okay, what's going to happen here? Well, when you tell the patient to bear down and taking a deep breath and bear down, what they do is they elevate intrathoracic pressure. Okay, that elevates the right atrial pressure. That then transmits to the inferior vena cava and the hepatic veins. It resists hepatic venous outflow. And that extra resistance of outflow may take stagnant flow and turn it into hepatofugal flow. You then tell the patient to blow it out and relax, as we did here, and 10 seconds later, now the flow is going into the liver. It's surging forward. Why? Because that intrathoracic pressure dropped briskly. All that resistance on the hepatic venous side went away, and all of this extra pressure that built here is now flowing through the liver. And so this is not a patient whose liver disease just spontaneously worsened in front of our eyes. This is the result of this Valsalva maneuver, and it helps you to avoid the pitfall of calling something thrombosed if the flow is really thready. What do you think of this portal vein flow tracing? Okay, that's what it should be like. A little bit of periodicity is okay, but this thing is like a roller coaster. It's really speeding up, slowing down. Why? Well, it has to do with capillary permeability. Okay? If you have a diffusely diseased liver, then the capillary bed becomes more permeable, and that arterial systolic diastolic pressure variation can bleed over onto the portal venous inflow side and create this velocity variation. Or perhaps the patient simply has a big internal arterial venous fistula, and so that may be causing that velocity variation. But there's another phenomenon that can do this to the patient, and that's the patient who has a cardiac disease. Perhaps the patient has tricuspid regurgitation. So remember, when the right ventricle contracts, it contracts with a massive amount of force compared to the atrium. And if the tricuspid valve allows that pressure wave to blast through into the inferior vena cava and back up the liver, it will significantly resist that portal vein inflow and add to that periodicity. So here you go. This is a patient with hepatitis, and they have a very leaky capillary bed. And you can see on this tracing, which incorporates both hepatic artery and the portal vein, that hepatic arterial inflow systolic blast coincides precisely with the reversed component, or at least the slowed component, of portal vein inflow. So the pressurizing of the liver during hepatic arterial systole resists portal venous inflow. Okay? It's a little trickier to do with the cardiac issues because portal vein is on one side of the liver, the hepatic veins are on the other side. So you kind of have to infer that. But, if you see a patient with an inferior vena cava that's distended and these big hepatic veins, I always pay attention and get a Doppler tracing, because that may be your first tip off this. This patient may have some severe cardiac disease. Look at this hepatic vein waveform. Is this normal? Not in the least. We do not have that 2 steps forward, 1 step back look. Instead, we've got 1 step forward and a big step backwards. Okay? So maybe this person has tricuspid regurgitation. Whenever you see this kind of a waveform, even if you're not trained in cardiac imaging, cardiac Doppler, you can tell there's something wrong and get this patient started on the course of an appropriate workup for cardiac disease. It's a useful finding. So this is the portal vein tracing in this person, and right here these dips in portal vein velocities. Although I can't get them on the same tracing because we're so far apart between hepatic veins and portal vein, you're rest assured that at this point during the cardiac cycle is when this reversal of flow occurred. So normal portal pressure, relatively low. With portal hypertension, it rises. It rises because the blood has a hard time getting through the liver, and it can get up to 30 millimeters of mercury. Normal portal gradient, less than 6 millimeters of mercury. Above that defines portal hypertension, but really it's clinically silent until it gets above about 12 millimeters of mercury. Above 12, then we start seeing clinical evidence of portal hypertension. Hopefully we can catch it before the patient develops those varices. So the portal triad is a combination of the bile duct, the portal vein, and the hepatic artery. And these go into the liver side by side. Here we are deeper into the liver, this nice Nutter drawing, and you can see bile duct, portal vein, hepatic artery. And, these are 3 tubular structures, so there's a little space between them, and the Mother Nature puts a little bit of fat there just to fill up the space, and that's why you have that bright porta hepatis appearance in an edematous liver. So as these further branches and goes into the liver, you get these very tiny little vessels, and these course between the sinusoids of the liver. The sinusoids are these little hexagonal-shaped tiles, and the blood from the portal vein will come out and then percolate across this cellular matrix until it gets to the central venule of the sinusoid, and from there, this will then go on to the hepatic veins. So this is where the business of the liver occurs, this little cellular network here, and so portal flow trickles across and goes to the vein. Now, when you have portal hypertension, you have resistance to this flow. And it can be pre-sinusoidal. It can occur in the branches of the portal vein even before the blood has a chance to get into the cells. It can be sinusoidal. It can be because of disease of the cellular matrix of the liver, or it can be post-sinusoidal. It can actually be an obstruction of the vein outflow. Okay, so the pre-sinusoidal, it's usually due to either portal vein obstruction, maybe a clot, maybe there's an arterial portal fistula that's outside the liver, or intrahepatic causes that, like fibrosis, Wilson's disease, sarcoid, or parasites. This will actually plug up the portal veins before the flow even has a chance to get out of the portal vein. Sinusoidal disease, that unfortunately is what we see the most of. The linaics, those are the alcoholics, and then hepatitis from whatever reason, and then these livers end up looking like this. This is the very gnarly looking cirrhotic liver. The surface of it is called the hobnail boot liver. Vincent van Gogh painted that. That's way back. That's how they used to get traction. They used to put these little hobnails into the sole of a shoe, and that's this surface. That's what reminded people of. So then when you have hepatic venous outflow obstruction, that's known as the Budd-Chiari syndrome. And most people, when you say Budd-Chiari syndrome, they immediately think of thrombosis. Well, it's correct, but that's only part of the syndrome. Anything that causes hepatic venous outflow obstruction is Budd-Chiari syndrome. And that can be due to cardiac disease. I already showed you one case with a tricuspid regurgitation. It can even be pulmonary disease. Anything that prevents flow from getting out of the liver into the heart will give you Budd-Chiari physiology and will affect hepatic venous outflow and therefore create portal hypertension. So the hepatocellular disease presentation depends on its severity. First thing you typically see is mildly elevated liver enzymes. Perhaps they get worse. And more often than not, somebody will say, well, let's get an ultrasound. Okay, liver enzymes are up. Let's see if there's anything there. And so we will image the liver. We will look to see if there's anything structurally abnormal. But I'll tell you, you don't often see much. You can have hepatocellular dysfunction, have a perfectly normal looking liver by ultrasound, but I would encourage you in that situation to look with Doppler, because Doppler and those changes in portal vein inflow velocity and the increasing hepatic arterial flow, it'll happen way before you're going to see any true imaging appearance. So if you have liver disease, that hepatic artery revs up. Those velocities are going to start going up as that supplies the liver disease. And then if it gets bad enough, you're going to start seeing a slowing of portal venous flow or maybe even reversal. Imaging alone isn't going to tell you that. Now here's a question for you. Reverse portal blood. Where's it coming from? What is giving us that? I mean, this blood has to come from somewhere, all right? It's coming from the hepatic artery. Because as the liver disease gets so worse, even the hepatic artery has a hard time getting its flow to that central vein. And what's the path of least resistance? Well, it's that portal vein that's sitting right next to it. And the flow shunts right across into that portal vein, and the result is hepatofugal flow. So interventionalists were imaging portal hypertension a long time. Here's an SMA arteriogram, portal venous phase, and you can see big engorged portal vein, attenuated intrahepatic branches, and then all of these guys. What is all of this? These are varices. This is the stomach. The spleen's already been removed from this patient, and these are varices in the stomach wall. And notice how right here, there's a real big cluster of them. This is where they become the esophageal varices. This is where the blood flow, which is likely reversed in this portal vein, will come into this area, into these vessels, and then up the esophagus into the azygos vein to the return to the systemic circulation. Now, there are multiple portosystemic pathways. Netter very nicely drew the portal circulatory system. Right here are the short gastric veins. They are between the upper portion of the spleen and the greater curvature of the stomach. On this side of the stomach, we have the left gastric or the coronary vein. This drains the lesser curvature, this drains the greater curvature. But when you have portal hypertension, these veins reverse flow and end up going up these little guys that are in the wall of the esophagus and up to the azygos vein to the systemic circulation. So this is a portosystemic shunt. All of us in utero had an umbilical vein. After we're born, it withered away. Never put the umbilicus over here just for convenience, but the withered umbilical vein, nevertheless, a little remnant still remains. And in about 20% of patients who develop portal hypertension, they'll actually recanalize it or develop a little paraumbilical vein. And so that flow from the portal venous system continues up in the portal vein of the liver, but it all goes into the left portal vein and down this shunt to the belly button, and from there back to the systemic circulation. Splenorenal varices are in the left flank, and these are typically communications between the blood in the splenic vein and the renal vein. And I will tell you, these are never direct communications unless a surgeon created it. Most often they're very convoluted, and they'll take up a component of mesenteric vasculature, maybe the retroperitoneal vasculature. Oftentimes they will find the left gonadal vein. In the research we've done, it's amazing how often splenorenal varices will find the left gonadal vein. And then there are hemorrhoidal varices. They're down here next to the rectum, because it's systemic circulation just outside and then portal circulation here. But that's a pretty rare portal hypertension varix. So why should we bother looking at these things? Well, several reasons. Number one, if a surgeon's going to operate this patient, it really is beneficial for them to know where these varices are. Varices are very thin-walled vessels. They are veins, so they're thin-walled to start with, and then they are over-distended, so they're thinned out even more. So if you're a surgeon and you are operating and you stumble into one of these things, they're hard to get control of, because as you start to tie them off or compress them or clamp them, they tear. They're just horrible at tearing. And so surgeons will do anything they can to avoid stumbling into a variceal bed. It helps a lot in planning transplant surgery. They need to stay away from these guys. And then it also helps in taking care of the portal pressures before the patient actually goes to surgery. Now, most of these liver transplant candidates, they'll have a TIPS, they'll have a shunt placed to decompress the portal venous system, to have these varices shrivel up, and in addition, these varices will be coiled. So for the next part of this talk, we'll bring in a little bit of CT and maybe a little MR. I'm going to show you the course of these varices because it's important for us to understand them. The unfortunate thing with ultrasound is we're kind of looking through a little keyhole. You can only see a little bit of the anatomy at the time. And these varices, they go from diaphragm to pelvis, from the left side of the body to the right. They're all over the place. So let me just kind of show you where they run so you know where to look for them. So we're going to be doing some CT 3D angiograms here, and I'm going to do it the old way with shaded surface display. So after a CT, we get the whole torso data set. We use some electronic scalpeling, electronic thresholding to get rid of the real light stuff. Then we create a bone model. We subtract that away. Then we use a little more electronic scalpeling to get rid of a few other structures, and we're left with the venous system. We can then split that up, color it different colors for the various components, and then put that back together again. I threw the spleen back in here. We'll throw it back into the body. So what do we got here? We have the portal vein right here. This is the SMV. This is the splenic vein. This is the inferior vena cava. And then here, this guy, this is a big inferior mesenteric vein varix going down towards the pelvis. And then see that yellow thing? That is the left gonadal vein coming up into the renal vein, into the IVC. So this is a portosystemic shunt. Very nice for the surgeons to know where they are. We can throw a little bone in there so you get the big picture because they want to avoid these things. Okay, left flank, longitudinal, diaphragms here, that's the spleen. Here's the stomach with a little fluid in there. What are these things? Turn a little color on. These are blood vessels, right? These are short gastric varices. They are typically north of the splenic vascular pedicle because they are going up towards the GE junction and then from there up the esophagus. So on a 3D model, here they are. They're typically a bunch of little small vessels. The stomach is living in here. There's the spleen, splenic vein here. They are north of the splenic vein. And I've always seen them in conjunction with the left gastric vein. It's very rare for them to be isolated. Here's another patient, same thing. There's the spleen. These vessels, splenic vascular pedicle is right here. These things are heading north, and combined with the left gastric, flow going up to the GE junction. There's the diaphragm. You can see the varices right here. They're very tortuous and convoluted. That's the pedicle, that's the splenic vascular pedicle. All of these things are heading north towards the azygos vein. The left gastric varix, typically it's one large vein. It'll eventually start to branch out. It heads off from here, or the coronary vein heads north towards the same area, and it shunts blood away from the portal system. This is what it looks like on ultrasound, behind the left lobe of the liver. Now, this is a problem because this is already a liver transplant recipient. This was like the 4th or 5th one we ever did at the University of Wisconsin. It was a long time ago. But this liver was not doing well. And the surgeon sent the patients to us to rule out hepatic artery thrombosis. That's what they always tell us, right? Well, the hepatic artery was fine. But what we found, to everybody's surprise, was this big left gastric varix with a lot of blood flow in them. Here's the angiogram that followed. SMA arteriogram, portal venous phase. So there is blood flow in this portal vein, but not very much. Look at the concentration of contrast here in this varix versus this liver. So this massive varix was not ligated at the time of surgery, and all the portal venous flow, instead of going through the liver, is short-circuiting. It is bypassing the liver and heading right to the systemic circulation. I mean, blood is stupid. It's just going to go against the path of least resistance. Why should it percolate through the liver when it can just easily flow right through this varix? So this is an unfortunate case. We identified the syndrome because of that, and now these varices are ligated or embolized prior to the patient going on for their transplant surgery. On a 3D reconstruction, this is what they look like. Superior mesenteric vein, splenic vein, portal vein, nothing. There's no branches of the portal vein in the liver because all the flow is just shunting up this massive varix. And you can see eventually these things bifurcate up and they're going right along the esophagus and in the esophageal wall. There's gas in the lumen of the esophagus right there, and then a big variceal plexus. Here's another patient. Same thing, very impressive collateral plexus. Endoscopists can see them. This is the esophagus, that's the probe, and all these little red circles right under them, those are the varices within the esophageal wall. Now, if you have one of these, this is bad. These are the varices that bleed. These patients bleed to death. It's very messy. I remember I was once in the intensive care unit when a patient came in with esophageal variceal bleed. There was blood everywhere. It was really a mess, and the patient didn't make it, unfortunately. So the left gastric varix, behind the left lobe of the liver, typically in a longitudinal orientation. Here's the cava, there's the left gastric varix. So if you want to find the left gastric varix, you go through the left lobe of the liver. If you find the short gastric varices, you go through the spleen or where the spleen used to be. Midline longitudinal image. Tubular structure heading out of the liver, going south with flow in it. Here's another patient, same thing. This is the recanalized umbilical vein or the perumbilical vein. Okay, so superior mesenteric, splenic, portal vein, right branch, left, flows coming down. So the blood flow, it wants to go up these veins, it wants to get into the liver, but it can't. Look at that liver, it's just cirrhotic. And so the flow goes left and then right down the umbilical vein, down towards the umbilicus. Now, it stays deep to the rectus sheath, right? That's where the umbilical vein ran. So it's behind that muscle sheath. From there, it can go in one of several different directions. We're not back to the systemic circulation yet. So in the classical teaching is that these patients will develop a caput medusa. This is a statue I found on a trip in Rome. This was, I think, in the Vatican, and it's the Medusa. It's the Greek goddess, and she had snakes in her hair. All right. So this is the most classic caput medusa I've ever seen in a patient. These blood vessels have blood in them that a couple of minutes ago was flowing through the gut, went up the portal vein, tried to get into the liver. It couldn't. It came down to the umbilicus, and then it flows via these branches in the body wall. And then from here, see right there, it disappears. It's punching through the body wall, going to find the external iliac vein, and from there, back to the systemic circulation. But to be honest with you, these are pretty rare. You don't see caput medusa that often. Here's another one. Here's the CT angio to go with it, and here's the clinical image of it. You can see these worms just deep under the skin in the body wall. That's that periumbilical vein. It got to the porta, to the umbilicus, and there you can see these. Okay, but those are rare. In most patients, that umbilical vein will continue on via an inferior epigastric vein, and from there down to the external iliac vein, and that way back to the systemic circulation. Probably 80% of patients with a periumbilical will have this. A lot of these people will also have flow that tries to go north. It goes up into the substernal region. These are small components, but nevertheless they can exist. Look at this one. So this one chose the right inferior epigastric vein. It's impressive. Left portal vein right there, out of the liver, down the body wall, all the way to the down the external iliac, into the external iliac vein right there. Here's the inferior epigastric on the other side. That's what the normal size of it should look like. And even in this patient too, notice there's a little substernal branch heading north towards the, just finding another pathway back to the systemic circulation. Now, unusual things can happen at the umbilicus. Remember, this vessel coursed out of the body wall normally. So for it to find the inferior epigastric, usually there's a little twist or two. Sometimes it's deep, and sometimes it could be superficial. This was a prisoner. He had umbilical hernia, and so they got the CT scan to analyze the hernia prior to taking it to surgery. What's this? That's the falciform. That looks a little prominent, right? Here's this thing going down. Well, there's his hernia, and there was some unopacified bowel in that neighborhood, so we got asked to look at this with ultrasound. So here's his portal vein, left branch going right into this umbilical vein. Portal venous flow profile, right down the anterior abdominal wall to the umbilicus, and from there, it went out under the skin. What happened? Well, is this a surprise to anybody? No, because that's the way the umbilicus went, right? It went out to the placenta. So it left the body at that point. And in a fair percentage of these patients, they will have a little knuckle of the varix that projects outside of the rectus sheath. And a little bit of a caput medusa trying to form here in this person. I got called to the intensive care unit in this portal hypertensive. They were trying to figure out what this was, and they were asking me if I would biopsy this. Let me give you a little advice. Do not biopsy this. This is the ultimate outie, right? This is a patient who has portal hypertension. Here's his 3D CT with this little variceal knuckle that is external to the skin. So this person, he's in risk of exsanguination. Don't deal with it. These things can be quite big and quite prominent. And we had this patient, we were going to do a paracentesis, and I couldn't help myself. So remember what I told you about a Valsalva maneuver and increasing the pressure in the portal venous system? That's what happened when I told him to bear down. He's resisting venous return, and so the whole portal venous system just engorged up that quickly, and this thing became more prominent. Varices can complicate the surgical approach to underlying pathology. All right, I'm in a liver transplant program. I see a lot of these patients, and you may say to yourself, well, this isn't important to me. I'm not going to be seeing these people. Well, guess what? You will, because they're out there. They may not be sick enough to be in a liver transplant center, but there's no reason that, just patient with mild liver disease may not have varices. Here's a perfect case. So a 52-year-old female presented to our hospital with left lower quadrant pain. She happened to be a doctor's wife. She had fever, elevated white count, and the clinician acutely said, diagnosed diverticulitis, okay? So he said to her, we need to do maybe a CT scan or a barium enema. She says, no, I don't want to go through all of that. So he called me up and he said, would you mind looking with ultrasound? Just tell me if she's got a big diverticular mass down there. What he failed to tell me, she also had liver disease. She was a 2-martini lunch kind of a gal, and she liked her wine with dinner. There was a past history of portal hypertension, but she apparently was behaving herself. All right. So here's this ultrasound of the left lower quadrant, and here within the circle you can clearly see this big, ugly mess. There's some air bubbles in it. This is a big diverticular process. Part of it's probably an abscess. It wasn't easy. It wasn't a hard diagnosis at all. But what's this? What is this structure that's got all this color in it right over the top of this diverticular mess? Well, I showed you this patient earlier. This is this woman that had the large recanalized umbilical vein going down to the inferior epigastric. This is where her abscess is. Guess where the surgeon would have had to cut if they were going to be approaching this diverticular abscess? Right through that varix. So when we found this, when we told them, the surgeons were extremely grateful to us. This patient went on to get antibiotics to cool off her diverticulitis. She got a TIPS. This got embolized, and then a month later, she had her surgery to rid her of that diverticular mess. If we had not identified this and pointed this out, surgery would have been a lot bloodier. So we made a big impact. Varices can sometimes go through the gallbladder wall, and everyone that I've seen in my career has always been associated with portal vein thrombosis. So here's a person, he had a hepatocellular carcinoma, and it was growing into his portal vein. He had his recanalized perumbilical vein down here, epigastric, right to the external iliac. But what's more important is what was going on in his gallbladder wall. You see these little whiskers over here? When we looked at it with ultrasound, you found these tubular structures in the gallbladder wall. When we turned on our color, there was flow in them. This was not cystic artery. This is part of the portal venous system. It was venous flow profile. Here's a latex cast. These are varices in the gallbladder wall. Here's another example, okay? And here's a good CT to go with it. If you look at this, there's a cavernoma here. This portal vein was thrombosed, and here in the gallbladder wall, you can see this large varix. So a nice example of a gallbladder varix with an associated sequela of thrombosis. Splenorenal collaterals can be enormous. They're out there in the left side of the body between the spleen and the kidney, and they go all over the place. They're huge tubular structures. There's the kidney, there's the spleen, there's the left renal vein right there with just a huge amount of flow going back to the systemic circulation. And these varices are huge. They are all over the place. Typically, they're heading down into the mesentery, and they very often involve that gonadal vein. So here's the 3D rendering, flow coming down into the pelvis, finding the left gonadal vein, left renal vein, up the inferior vena cava. Another one, big complex mass of vessels coming down, finding the gonadal vein, up left renal vein, back to the systemic circulation. This is the most direct one I've seen between renal vein and splenic vein, and it too, very convoluted course. So if you're going to be looking with Doppler, and you're going to be looking for varices because you got reverse flow in the portal vein, look out around the spleen, look out around the left kidney. You'll be amazed what you find. Remember this one I showed you earlier? Same thing. Instead of SMV, it's finding the IMV down to the plexus, down to the pelvis. How about this one? This one took the SMV down to the right lower quadrant, and it too found a gonadal vein back to the inferior vena cava. This was a wild one. This is a left gastric varix that never really made it to the esophagus. It took a turn and came down the left adrenal vein to the left renal vein and back to the systemic circulation. Varices can be really wild. Here's one that's taken this, it's probably the IMV, and it's going down to the paraumbilical region, and from there back to the systemic circulation. Here's a IVC direct, SMV shunt that goes directly to the inferior vena cava. It found a lumbar vein. Get the picture? These things can be anywhere. All right, so you're doing a pelvic ultrasound because a woman has a palpable mass in the adnexa and they think it could be ovarian cancer. Big ugly mass, multicystic. Ovarian cancer? Not after you turn on the color. This is another one of these large variceal plexus all the way down into the pelvis. And finally, here's two nice CTA examples of a hemorrhoidal variceal plexus. You can see that it comes down from the IMV and into this large plexus behind the bladder. I'm not going to do transrectal ultrasound to find these things, but just be aware they do exist. There's some other new tools to help us identify portal flow and portal circulation. This is a tool called PC Viper. It's an MR-based tool that's developed at the University of Wisconsin. It can very nicely show portal flow and identify portal varices in the big picture. And the nice thing is it doesn't require radiation. Here you can see this patient had portal vein thrombosis. There's no flow in that segment. Flow from the spleen is leaving the spleen, but it's going south in the superior mesenteric vein. I don't know where it's going to find some collateral communication. And interestingly, the left portal vein flow is hepatofugal. Right portal vein flow is hepatopedal. All right, just a few other custodial items. This is the region of the portal vein. What do you think of this appearance? This is a cavernoma. It's cavernous transformation of the portal vein after thrombosis. In these patients, they recollateralize flow, but it's never one robust vessel. It's typically a lot of little small ones, and you see all these little serpiginous structures. Here's another example of one, and typically they will have just multiple little vessels coursing through this region, and they can penetrate a fair distance into the liver. Notice this left branch really extends out there. That cavernoma extends well into the left lobe of the liver, so just don't be surprised when you're looking with your Doppler. Flow in the portal vein can sometimes be seen to be helical, and this MR very nicely shows us why. It is not a manifestation of any kind of pathology. It's simply how the fluid stream from the SMV and the splenic vein converge within the portal vein. Instead of fusing in parallel, they spin around each other. All right, what do you think of this portal vein? Here it is. It's kind of a tube, but it's very echogenic, right? And so there's thrombus within this. But what kind of thrombus? It could be bland thrombus, right? Well, we threw a little color on there, and all of a sudden we're seeing color within it. So what do we have to consider? We have to consider tumor thrombus. When you look, this is blue. So the direction of flow is actually away from the transducer. And that makes sense because the tumor originates in the liver, and as it grows out, it's going to bring the neovascularity with it in a downward direction. And then what'll finally clinch it, if you get a spectral tracing and you find an arterial waveform in the portal vein, that's tumor thrombus being supplied by the hepatic artery. So in conclusion, variceal pathways can be just about anywhere. If you see reversed flow in the portal vein, take a little effort and search around the body to try and find these things. They are critical in the pre-transplant patient. It's important to identify them so that they can be thrombosed. It'll increase the likelihood of success of the liver transplant. And even if you're not in a transplant program, you could really make a surgeon happy by identifying these, because an unsuspected varix can just ruin a good surgeon's day. The caput medusa, it's a rare finding. It's only present in a small percentage of patients with the recanalized paraumbilical vein. When you have a cystic mass in the pelvis, don't forget to turn on a Doppler. It's a useful tool. It's a piece of the puzzle. It helps us make diagnoses, but you have to use it. Thank you.